Hello, everyone. We will begin momentarily. Hello, everyone. Good morning and good afternoon for folks on both coasts joining us today. My name is Twin Tran. I am APCHO's Training and Technical Assistance Director. And on behalf of the members of the Special and Vulnerable Population Diabetes Task Force, I welcome you to today's webinar. The final webinar in our 4-part learning series on diabetes among special and vulnerable populations. Today's webinar is focused on diabetes clinical management and periodontal care for diabetic patients and individuals experiencing homelessness. Presenters on our webinar today will cover the ADA most recent standards of medical care in diabetes, the role of oral health and dental conditions in patient diabetes management, and strategies for addressing diabetes in public housing and individuals experiencing homelessness. Today's webinar speakers and content represent a collaboration between our 3 national cooperative agreement partners. The first is the National Center for Health and Public Housing. Our second national partner is the National Network for Oral Health Access. And finally, we have our third national partner in the content and the speakers today is the National Healthcare for the Homeless Council. You can visit each of their organizational websites for further information. And even though content for today's webinar was a collaboration between our 3 NCA partners, we would like to recognize all of the other NCAs for all their support and participation in this Special and Vulnerable Population Diabetes Task Force. And this is to just ground you in where the 4-part learning series on diabetes fit within the structure of HRSA-funded diabetes activities for 2017 to 2018. And this is our special piece on the Special and Vulnerable Population Diabetes Task Force. And there are other diabetes task force and work groups that's happening concurrently as well. And this 4-part webinar series is just to really provide you with some very introductory information. And then in the next year and the following year, we'll be able to provide dive deeper into some of the content that we have presented here in this 4-part series. Okay, so before I go into speaker introductions and the content, there's a couple of housekeeping items. If you are not familiar with GoToMeeting, you are looking at an example of the GoToWebinar attendee interface, and it's made up of 2 parts, the viewer window and the control window. The viewer window allows you to see everything that we are sharing on our screen, and the control window allows you to send questions to us as we go along. By clicking on the orange arrow button, you can hide or show your control panel. Please note that for this session, attendees are in listen-only mode. You may submit questions and comments by typing them in the questions field. We will be reviewing them as they come in, but we'll address them after our panelists have gone through their presentations. So today's webinar is being recorded, and after the webinar, you will receive an email with a link to view the recording as well as the PowerPoint presentations used in today's webinar. Please also don't forget to fill out the post-webinar survey and indicate whether you like to receive an electronic or hard copy of the CME or CNE accreditation or a certificate of attendance. With that, I'm going to provide a brief intro of our panelists for our call today. The first is Dr. Jose Leon. Dr. Leon is the Chief Medical Officer for the National Center in Public Housing. In his role, Dr. Leon provides training and technical assistance to community health centers serving public housing residents on emerging clinical topics and quality improvement, quality assurance, systematic actions that lead to measurable improvement in healthcare services, and the health status of underserved and vulnerable populations. Dr. Leon has authored over 100 articles on public health and emerging medical issues in Spanish and English. Our second panelist is going to be Dr. Andrea Charrington, and she is an Associate Professor of Medicine at the University of Alabama, Birmingham, in Birmingham, Alabama. She directs the university program in clinical and population health science, as well as the intervention and translation core of the university's Diabetes Research Center. She's also involved in several projects that seek to advance the methods of community-based intervention delivery by combining the community health worker model with multi-component technology-assisted support systems. Our third panelist is Irene Hilton. Dr. Hilton is the dental consultant for the National Network for Oral Health Access. She is also the clinical staff dentist at the San Francisco Department of Public Health. She also serves as a clinical instructor in the Department of Community and Family Medicine at the University of California, San Francisco. And our fourth panelist is Tracy Tinker, and she has been a nurse case manager at the Healthcare for the Homeless program of Catholic Medical Center in Manchester for 8 years. As a certified diabetes educator, she is a passionate advocate for client-centered goal setting with her clients with diabetes and pre-diabetes and helping them to successfully achieve their self-management goals. And in 2013, Tracy worked with a multidisciplinary team partnering with the National Healthcare for the Homeless Council to update the diabetes adaptive guidelines to help address the special challenges that patients experiencing homelessness face to manage their diabetes successfully. So with those introductions aside, I'm going to pass control over to Jose. And Jose, you should now get control and start.
Thanks, Tuan, for this great introduction. Can you see my screen, Tuan?
Yes, I can.
All right. Well, thank you so much for your kind introduction. My name is Jose Leon. I am the Chief Medical Officer at the National Center for Health in Public Housing. It is a great honor to be part of this panel and talk a little bit about public housing, provide some quick overview of the health picture of public housing residents, and talk a little bit about public housing primary care and the activities that we've been conducting since July 1st, 2017 on diabetes, specifically some of the findings and best practices that we have collected from our diabetes clinical quality working group. This is the list of health centers that have been participating in our clinical quality working group. We have 10 community health centers that are located in or immediately accessible to public housing. And we've been conducting quarterly calls to gather some best practices and some recommendations from the health centers and who have been sharing their experiences in regards to diabetes. We also have the participation of Massachusetts Primary Care Association and other NCAs that have been collaborating with us. In regards to HUD assisted programs, I would like to focus on public housing, primary care specifically, and specifically this is public housing. There are the HUD, the U.S. Housing and Urban Development Federal Agency, have three main programs: the voucher program, the public housing program, and the multi-family program. The one that we are going to focus on is the public housing program, and as you can see, 31% of those receiving assistance from HUD are living in public housing. This is a very special population. You have people who are experiencing homelessness or who are coming from homelessness, people with HIV/AIDS, and people returning from prisons living in public housing. In addition, we have some vulnerable populations, specifically people who are 65 years and older, and people experiencing some kind of disabilities. We conducted this survey this year just to check on the social determinants of health affecting public housing residents. And the public housing primary care grantees gave us some very good understanding of the SDOH affecting public housing residents, specifically poverty, poor access to healthy food, unemployment, violence and crime, and lack of transportation, as well as low educational attainment are some of the SDOH affecting public housing residents. So what we did is that we created this tree to show all these social determinants of health affecting public housing residents. And you will see this tree on other slides, because this is one of the sessions that we focused on. We discussed diabetes and how health centers are addressing social determinants of health. In regards to the demographics of public housing residents, there are 2.2 million people living in public housing. The average household in public housing is 2.2 people. 38% of them are children, and around 16 to 17% are people who are 16 years of age and older. 35% of them are on welfare, and over 83% of them are at or below the 100% poverty line. These are two studies that I've been reviewing lately. I would like to focus on the one that is on your right-hand side. This research was published yesterday, and it was in the New England Journal of Medicine. Specifically, it was focusing on the prevalence of housing problems in community health center patients. And according to the report of the research, almost 44% of those of the patients being served in community health centers reported some kind of housing problems. Either they were experiencing homelessness, or they had unstable housing, or they were reported being double up. So one of the recommendations from the study is that community health centers should consider universal screening for housing status for all patients. And that's one of the things that is being addressed by the PREPARE tool, the NAC PREPARE tool. The health centers located near public housing in 2016, that is the most recent data that HRSA has available, 341 health centers reported being in or immediately accessible to public housing, and they serve around 2.7 million patients in 2016. Out of the 341 health centers, 105 are public housing primary care grantees, and these are those receiving federal funding from HRSA to provide services to public housing residents. In 2016, they served almost 610,000 patients. In regards to diabetes, the number of patients with diabetes in public housing primary care sites have been increasing. Since 2012 to 2016, there has been an increase of almost 6% of the total number of patients, and they have been diagnosed with diabetes. Now, this is about the same number that was reported by the Centers for Disease Control. However, when you look at the patients with uncontrolled diabetes in public housing primary care, 32% of them have an hemoglobin A1C greater than 9. We've been working with all these organizations, including HUD, CDC, and we have developed some maps to help the grantees, the PHPC grantees, to better understand the diabetic or the issues of their diabetic patients. Specifically, the maps on your right hand side basically is showing the percentage of patients with uncontrolled diabetes in the 105 public housing primary care sites. And the map is interactive, so if you click on any of these dots, you also have the number of patients with diabetes that have been reported by the health centers. This interactive map is on our website. If you would like to look at the numbers or learn a little bit more about this tool, you can go to our website. These are the health centers that have been participating. As I mentioned before, we have 9 public housing primary care grantees, 1 health center in Tucson, Arizona, that been collaborating, and it's not a PHPC health center, but they have been providing great information about diabetes and how they are addressing diabetes. I would like to invite all the health centers that are participating right now, that if they would like to be part of this initiative, my contact information is on the last slide of my presentation. So if you're interested, you can always either call me or send me an email. Now, we've divided our training into different buckets. Right now, we are addressing diabetes prevention, and next program year, starting July 1st of this year, we're going to discuss diabetes management. For the 2 calls that we have had so far, we have talked about social determinants of health, pre-diabetes, and community-based and weight control models. Tomorrow, we will be addressing workforce issues in regards to diabetes prevention. Now, this is the tree again, and when we had the conversation on social determinants of health, I believe by November of last year, we discussed poor access to healthy food. Some of these public housing programs are located in what are food deserts. And I have some highlights from the conversations. TCA Health Center in Illinois, for instance, they have a green veggie bus. They go to the health center and provide low-cost vegetables to all patients. La Maestra Community Health Center in San Diego has a community garden and a food pantry to address the poor access to healthy food. And the Rio Health Center in Arizona, they have a farmers market prescription program and a park prescription program. So what they do is that they prescribe some healthy food to the patients, and they can go to the farmers market and obtain the food that are recommended by either the nutritionist or the doctor. They also have some agreements with the park, and they provide free transportation to the park, and they have some programs so patients can do outdoor activities and exercise. In regards to the other social determinants of health that we addressed, community violence, TCA Health Center in Chicago, Illinois, they have a wellness exercise program. After 6 o'clock, the public housing residents do not like to go out and exercise, so they have a wellness exercise program in the evening hours and twice a week, and that is how they are addressing some of the issues that the diabetic patients can have in regards to community violence. And it's La Maestra Health Center in San Diego has a nutrition and exercise program similar to the one that TCA has in Chicago. In regards to how they are using electronic health data to address social determinants of health, the 3 examples that I have on this slide are Rio Health Center. They have a kiosk-based survey. All new patients can go to the kiosk, fill out the forms, and based on the responses and the needs, they are referred to the nutrition and exercise programs. La Maestra Community Health Center has embedded in their electronic health record system a template to address social determinants of health. And since they have a very diverse population and with people from all over the world, some of the biggest issues that they have is health literacy. So the information is used by the pharmacist and all the pharmacy staff to address any issue that the patient may have in understanding the prescription. And San Isidro Health Center in San Isidro, California, they survey the community. Specifically, they use outreach workers to address or to find some needs in the community, and based on the responses, they tailor programs for these communities, specifically programs that tackle diabetes. The other issue that we discussed during the last couple of calls is prediabetes. La Maestra Health Center, for instance, they have registered nurse, which is the case manager, and assess knowledge of the patients, of the condition, whether the patient understands what prediabetes is. And based on, after the assessment, they refer the patient to a 6-class program where they receive education on diet and exercise and how to read food labels, count calories, and lose weight. El Rio Health Center has a 6-week exercise program, and they combine the exercise program with a nutrition program. So they provide some health education for 30 minutes and 45 exercise classes, 45-minute exercise classes. And they also have an evidence weight management program where they provide education on lifestyle changes, medications, and surgery for those who are experiencing obesity, for instance. They also have a CME training, and what they are trying to do is to have obesity care providers. In regards to community collaborations, the South End Health Center in Boston, they are doing outreach, and specifically they are talking with the public housing agencies and being educated patients in different health conditions such as diabetes, smoking cessations, and providing information about the services. We have a community health center in Texas, Community Healthcare Center, and they have community collaborations with two organizations, with the local Department of Health, and they are also working with Interfaith Outreach Services. Interfaith Outreach Services provide some financial assistance for those patients who cannot pay for their medication. And they are working with the local Department of Health to provide diabetes education and cooking classes. In regards to exercise and weight control programs, that is another topic that we've been discussing with them. El Rio Health Center combined the nutrition and exercise program. They noticed that they had a lot of diabetic patients attending the exercise programs, but the participation in the nutrition program was not good enough. So what they did was to combine both programs and provide 30 minutes of nutrition education and then 45 minutes of exercise and all kind of activities for the patients. They also have motivational interviews and provide patient education during the same time. And they have another a program that is the Weight First approach, where they have weight management groups for those who have either diabetes or prediabetes. Now, all health centers that participate in are patient-centered medical homes, and they use specialists, residents, physicians, nurse practitioners, behavioral health specialists, and all the clinical staff that they need to provide services to the diabetic patients. One of the things that most of the health centers recommended is the use of retinal cameras to have them on site. So when the patients have need to have the eye exam, they receive that in-house and they don't have to refer the patients out. Some of the health centers are also working on research opportunities. We have Community Healthcare Center. They are working with the American Academy of Family Practitioners. The study is to look at the barriers to lowering A1C levels. They have a 5-question survey addressing food insecurity, opportunities to exercise, cost of medication, etc. And if they have patients, and specifically with some needs that they cannot cover, then they refer the patient to YMCA or the Department of Health. They also are working on another study on retinal damage and patients with diabetes and hypertension. Sioux Falls Health Center is working with the local Department of Health. This is another research, and they are measuring the use of electronic health records on diabetes and the use of a dashboard to identify high-risk patients and plans and follow-up visits. This is some information on how to improve attendance at the diabetes education meetings. They believe that the direct conversation with patient is the best way to communicate the patients, to answer their questions, and to remind them about the use of the medication or any other, and address any other barriers that the patient may have to attend the clinic. They also provide transportation, which is another issue that was mentioned in the survey that we conducted, and they have flexible scheduling, specifically for the educational courses, and they are providing those classes either in the evening or weekends to accommodate working or a patient who work out who attend college or school. And they also provide childcare for those busy parents who cannot attend or who cannot go to the health center because they have little children. So that is what they are doing. As an NCA, we are working we have our learning collaborative. We are working with the Special and Vulnerable Population Task Force, that we are very proud of being part of them. We are working with NAC and in the Clinical Change Package for Diabetes Care group. And we are very proud that we were invited by the American Diabetes Association to be part of the Primary Care Advisory Group. Health centers are also doing other activities. They are working on precision medicine and genomics, even though we are a little bit far away from the use of genomics and diabetes. These health centers are working with the National Cancer Institute, for instance, and providing talking to patients about the services on precision medicine, specifically for those who have been diagnosed with cancer. And this is my contact information, my phone number, my email address. If you would like to know more about the activities that we are doing, if you would like to be part of our learning collaborative, or if you have questions about the map that I described, do not hesitate to contact me. I will be happy to talk to you. Thank you and have a great afternoon.
Thank you, Dr. Leon. So up next, we have Andrea Charrington. So Andrea, are you on the line with us?
Hi, yep, can you hear me?
Yes, great.
Okay,
I'll
great.
advance
Yep,
the slide deck for you. Okay.
Okay,
right.
That sounds great. Yeah, go ahead. Okay, great. So I just would like to say thank you very much to Jose and others for the opportunity to be here today and share with you an overview of the 2018 American Diabetes Association Standards of Medical Care in Diabetes. The standards comprise all of the current and key clinical practice recommendations from the ADA. You can go ahead and advance the slide. This is my disclosures. They are not related to anything I'm going to talk about today. Thank you. Okay, so I just want to make a couple of notes about the standard of care. Oh, you know, I guess I'll tell you to click. So you can go ahead and click them all if you want. The association, oh no, go back to the last slide, sorry, thanks. Funds the development of the standards of care and all the association's position statements out of its general revenues and does not use industry support for the purposes of these guidelines. The slides are organized to correspond to different sections of the 2018 standards. And as we go through, I'll try to make a note of where they are. Most of what we're going to talk about today is found in Chapter 1, but there's a few other components that I added in from other chapters. And as with all the association position statements, the standards of care are reviewed and approved by the association's board of directors, which includes healthcare professionals, scientists, and lay individuals. You can go to the next slide. Thanks, and you can click 3. The standards of care, are revised annually by the ADA's Multidisciplinary Professional Practice Committee. For the 2018 revision, Professional Practice Committee members systematically searched Medline for human studies related to each subsection that had been published since January 2017. And then the recommendations are revised based on new evidence, or in some cases just to clarify prior recommendations and match the strength of the wording to the grade of evidence. The ADA and the Professional Practice Committee welcome feedback from the larger community. So you can see the URL that's listed there if you have any feedback on anything that I talk about today or anything that you come across in the standards. Please feel free to share it. Next slide. I just want to make a note about the standards in general moving forward. So from here on out, the standards of care will be the ADA's sole source of clinical practice recommendations. They're actually phasing out the position statements. The standards will now supersede all previous ADA statements. And the Professional Practice Committee updates the standards, as I mentioned, annually, but will also be updating it more frequently online if there's some major new evidence that comes out that merits a change in the recommendations. And again, the Professional Practice Committee and the association in general welcome proposals from the larger community for meetings. and official ADA documents. So you can submit that to the URL that's listed. Next slide. Okay, and this is just, I just wanted to orient you guys, if you hadn't taken a look at the standards before, to the grading system. And you can just see, so each of the standards recommendations, let me turn that down. Each of the standards recommendations is accompanied with an evidence grade. And you can see an evidence grade of A means that there's very clear evidence from well-conducted generalizable randomized controlled trials. And then as you go down, B and C, the rigor of the evidence, may not be quite at the same level. And then E really is expert consensus, and there may not be randomized controlled trials, but the feeling amongst the experts is that it's sufficient to make it a recommendation. Okay, next slide. Okay, so with that, I'm going to talk about improving care and promoting health in populations. You can go to the next slide. So clinical practice guidelines are key to improving population health, as you guys know, but in order to really achieve optimal outcomes, diabetes care must be individualized for each patient. And so efforts to improve population health are really going to require a combination of systems level and patient level approaches. Next slide. So with such an integrated approach in mind, the ADA highlights the importance of patient-centered care, which can be defined as care that is respectful and responsive to individual patient preferences, needs, and values, ensuring that patient values guide all clinical decisions. And really, I think that means, keeping in mind that a one-size approach doesn't fit all. Next slide. I like this slide because I think it really highlights that idea. So some of you may have seen this. This is actually not in Chapter 1. This comes from the chapter on glycemic targets. And for those of you who haven't ever seen this slide, I'll just walk through it a little bit. If you go down the left side, you can see a series of patient or disease-specific characteristics with a corresponding target A1C impact scale on the right. So for example, risk of hypoglycemia, disease duration, and then you look across to the right with the A1C impact scale. And the small end of the triangle aligns with a more stringent A1C target, and as it gets fatter, and it aligns with a less stringent A1C target. So just to give you the sense of how that works, if you take the first one as an example, the red triangle, for patients at a low risk of hypoglycemia or other adverse drug effects, a more stringent A1C target would be considered, while those who are at higher risk, a less stringent A1C target would be more appropriate. So you might imagine that this could occur, for example, in the setting of a patient with significant food insecurity. If you knew that there was a high risk for hypoglycemia because of lack of access to food, you may be more allowing in terms of your glycemic target. The patient and disease features are grouped into two categories, and you can see this along the far right. And that is the ones that are usually not as modifiable. So that might be things like disease duration, if somebody's had, the disease for 1 year versus 20 years, or life expectancy, and that's not typically that modifiable, versus factors that may be more modifiable, such as patient attitudes and expected treatment outcomes, or resources and support systems that may fluctuate over time. So where possible, decisions about A1C goals should be made in conjunction with the patient, reflecting his or her preferences, needs, and values. Next slide. In the spirit of tailoring treatment goals, I want to mention it again. This comes actually out of the lifestyle modification chapter, as opposed to Chapter 1, which is really where they talk about the impact of psychosocial issues. But I felt like it was an important point to bring up, because it's important to keep in mind that the emotional well-being is a key part of diabetes care and self-management. We know that psychological and social problems can impair the individual's or family's ability to carry out diabetes tasks and can therefore compromise their health status. So the association offers several recommendations specific to psychosocial concerns, and you can see those listed here. The first one is that psychosocial care should be integrated with a collaborative, patient-centered approach and provided to all people with diabetes, with the goal of optimizing health outcomes and health-related quality of life, and that's got an evidence level of A. And then the second one is psychosocial screening and follow-up may include, but are not limited to, attitudes about diabetes, expectations for medical management and outcomes, affect or mood, general and diabetes-related quality of life, available resources, that includes financial, social, and emotional, and then psychiatric history. And you can go to the next slide. And then finally, providers should consider assessment for symptoms of diabetes distress, depression, anxiety, disordered eating, and cognitive capacity using patient-appropriate, standardized, and validated tools at the initial visit, at periodic intervals, and then when there's a change in disease, treatment, or life circumstance, and including caregivers and family members in this assessment is recommended. You can go to the next slide. I wanted to just be specific about talking about depression, which we know affects 1 in 4 patients with type 1 or type 2 diabetes. So it's very prevalent and actually has an increased prevalence among patients with diabetes. Recommendations related to depression are that providers should consider annual screening of all patients with diabetes, but especially those with a reported history of depression for depressive symptoms with age-appropriate depression screening measures. And those are highlighted in the standards in chapter 4. These recommendations on depression come out of the chapter on comorbid diseases. So it would be in that chapter, not in the lifestyle chapter, if you're looking for them. And then recognizing that further evaluation will be necessary for individuals who have a positive screen. And then beginning at diagnosis of complications or when there are significant changes in medical status, consider assessment for depression, recognizing that, someone's mood status may change as their disease changes. You can go to the next slide. Referrals for the treatment of depression should be made to mental health providers with experience, if possible, using cognitive behavioral therapy, interpersonal therapy, or other evidence-based treatment approaches in conjunction with a collaborative care with the patient's diabetes treatment team. Go to the next one. And then for serious mental illness, it's recommended to annually screen people who are prescribed atypical antipsychotic medications for prediabetes or diabetes, since they can be related to the development of diabetes. If a second generation antipsychotic medication is prescribed for adolescents or adults with diabetes, changes in weight, glycemic control, and cholesterol levels should be carefully monitored, and the treatment regimen should be reassessed. And then finally, it's recommended to incorporate monitoring of diabetes self-care activities into treatment goals in people with diabetes and serious mental illness. You can go to the next slide. I wanted to specifically mention diabetes distress because it's, number one, very common, but it's also distinct from other psychological disorders. Diabetes distress is defined as significant negative psychological reactions related to emotional burdens and worries specific to an individual's experience in having to manage their diabetes. The ADA recommends routinely monitoring people with diabetes for diabetes distress, particularly when treatment targets are not met and or at the onset of diabetes complications. And you can find in the standards of care a couple of different validated tools to measure diabetes distress. If diabetes distress is identified, then that person should be referred for specific diabetes education to address areas of diabetes self-care that are most relevant for that patient. You can go to the next slide. So I'm going to switch gears a little bit now from sort of the psycho part to the social part and talk about tailoring treatment for social context. The ADA standards include recommendations specific to this. And the first one is that providers should assess social context, including potential food insecurity, housing stability, and financial barriers, and apply that information to treatment decisions. And I think that's right there, very consistent with what we just heard Jose talk about in the previous section. Next. They should refer patients to local community resources when available. And then next. and provide patients with self-management support from lay health coaches, navigators, or community health workers when available. And I think these recommendations are also particularly relevant when, and if you do screen someone for diabetes distress and it's positive, sometimes just linking people to resources and connecting them to something, someone like a community health worker can also help to ameliorate that diabetes distress. Next slide. So I just want to mention a word or two about health inequities. We know that health inequities related to diabetes and its complications are well documented and are heavily influenced, as Jose also started to outline, by social determinants of health. Next, you can click, yeah, thanks. Social determinants of health are defined as the economic, environmental, political, and social conditions in which people live and are responsible for a major part of health inequality worldwide. Next slide. Unfortunately, social determinants of health are not always recognized and often go undiscussed in the clinical encounter. Next click. So creating systems-level mechanisms to screen for social determinants of health may help overcome structural barriers and communication gaps between patients and providers. There's in chapter 1, there's several different references to repositories of tools and measures that could be used and embedded in the electronic medical record if possible, or else done on, with paper, to systematically capture information around social determinants of health in the clinical encounter. Next. I just wanted to mention, you can click all three. So there's particular emphasis on food insecurity, homelessness, and language barriers, along with treatment recommendations specific to each of these. Oh, go back, yeah, thanks. As well as tools that are referenced in chapter 1 that you can use to screen. There's some very brief instruments that you can use to screen for each of these, and then treatment recommendations around the use of insulin or the use of oral medications given some of these specific situations, and then some resources that can be used when encountering patients who may have a language barrier or even a literacy, have low literacy or low numeracy. Next. You can go ahead. Next. I just wanted to highlight a couple of things before finishing. The 2018 standards of care are available online. The full version is there for free. There's an abridged version for primary care physicians. There's also a free app. There are pocket cards with key figures, such as the one that I was describing at the beginning with the glycemic targets and some of the factors that need to be considered when identifying a particular patient's glycemic target or goal. There's a free webcast for continuing education credit that can be accessed, and all of this can be found through the ADA website at the URL listed there. Next. In terms of professional education, there are a lot of different options. There are live programs that are done through the ADA, online self-assessment programs, as well as online webcasts that are also accessed through the URL that you see listed there. Next. There is also a mechanism for identifying self-management education programs across the United States. There are also mechanisms to become a recognized diabetes self-management education program, as well as tools and resources that can be used, and online education documentation tools that can be used by programs once they are providing diabetes self-management education. Next. Okay, just a plug for professional membership for anyone who's interested. There are journals. It provides access to meetings, books, and journal discounts. There's a career center, quarterly member newsletter, and all of this, again, can be accessed through the website. Next. So with that, I thank you very much, and I think we're going to do questions at the end, so I'll hang around. I'll turn it back to you.
Great. All right. Thank you so much, Dr. Charrington, and thank you for sharing all the great resources as well as the evidence-based guidelines. So up next, our next speaker is Dr. Irene Hilton. And you're all set to go. Just let me know when to advance the next slide. Irene?
I'm sorry about that. I was muted, of course. Thank you so much. Welcome, everyone. And next slide. Okay, so my name is Irene Hilton. I'm from the National Network for Oral Health Access. I'm going to be talking for 15 minutes about oral health and diabetic patients with diabetes, to remind everybody that you cannot have good health if you have bad teeth. Go ahead, next slide. So the objectives for my brief presentation is to have everyone understand the impact of oral health and dental conditions in patient diabetes management, learn how to screen patients with diabetes for periodontal disease and other oral conditions, and then describe some strategies to address the challenges in referring health center patients with diabetes for dental care. Next slide. So briefly, patients with diabetes can have a lot of oral manifestations. Periodontal disease, people with diabetes are more likely to get periodontal disease or gum disease. And then if they get it, it's usually a more severe case than people that don't have diabetes. Patients with diabetes can experience xerostomia, whether as a result of the disease itself or because of side effect of the medications that they're on to control the disease. And when you have xerostomia and you don't have saliva, that puts you at additional risk for getting dental cavities, dental caries, because saliva acts as a buffer for the acids in the mouth. And of course, once you start getting dental cavities or your cavities get worse and you experience tooth loss, then you have the issue where you can't chew and bite as well as you used to, and then the diet changes and you get away from healthier, fruits and vegetables and into more high carbohydrate, which just makes the diabetes control more difficult. Also, patients with diabetes experience more oral candidiasis, lichen planus, burning mouth syndrome, and alterations in taste. So again, there really is a relationship between diabetes and a person's oral health. Next slide. And starting to talk about the reverse, and this is like the one clinical slide, is the relationship, the bidirectional relationship between periodontitis or gum disease and diabetes and glycemic control. And the reason that they're related is because both diabetes and periodontitis are essentially inflammatory immune-mediated disease. It's your own body does it to you. And the way that periodontitis starts is on the left, you can see a tooth, and where the reddish stuff is, that's your pocket, the pocket between your tooth and your gum. And over time, as a combination of genetic and environmental factors, you get junk in there, and your own body starts to send your immune system against the junk, and that produces all of these inflammatory markers, the ones in the red box, which are the same markers that you see in people with cardiovascular disease events and diabetes, these inflammatory markers, and that's what starts the cascade of eventually, losing bone. So again, and that's when you, again, have gum disease, periodontitis. So the cascade is essentially the same, again, which is why the two conditions, there's a relationship, association between gum disease and diabetes. Next slide. So again, what we know is, again, that people that have diabetes, tend to have more gum disease and more severe gum disease. However, at the same time, people with uncontrolled periodontal disease, that can also affect the glycemic control. Now, when they have done randomized clinical trials, because everything is multifactorial, so when they've actually taken, again, randomized blinded clinical trials of patients that have H1C levels between 7 and 9, so it's kind of like moderately controlled, but not completely controlled, but not out of control. Because again, when you look at most of these studies, they're not looking at people with H1Cs over 9. And again, when they did the randomized trials and cleaned people's teeth, there was only what we call short-term effect between 3 and 6 months that would lower the H1C. And after 6 months, that would go away unless you get treated again. However, again, most of these trials have not focused on people that you would say are out of control over 9. And if you look not at randomized clinical trials, but you look at health services studies, if you look in the insurance world where people that are insured, and it's true that most of this is commercial insurance, both in the medical and dental, the same insurance, so they can track this. Those studies tend to show that people that had diabetes and get periodontal, get dental care, utilize both parts of the insurance, tend to have less cost on the medical side. So again, if you're a clinician and you have patients that are out of control, over 9, you may want to think about whether or not they do have gum disease, because they may experience improvement if they get periodontal treatment. Next slide. See, and the reason that, again, if you're out of control, it kind of makes sense is because when you think about, again, a foot ulcer, and a common a condition that can appear in patients with diabetes, and the area of a foot ulcer, and you think about the area of gum, gums in a patient's mouth, which is approximately about a 2 by 4 inch area of skin. And if you have that level of chronic inflammation, how can that not affect your glycemic control? So again, just makes sense that, again, people that do have like severe levels of gum disease, should get their perio addressed. That may help, again, their glycemic control. Next slide. So part of a couple of years ago in 2014, HRSA put out a white paper and started this integration of oral health and primary care practice initiative. And the white paper is on the left. And as part of that, NOAA received supplemental funding from HRSA to develop this kind of cookbook, guidebook about how to integrate oral health into primary care practice. And again, the websites for both are here on the slides. Next slide. So HRSA held several meetings, and in the white paper, they talk about that these are the 5 oral health core clinical competencies that they would like providers in health centers to have in order to be able to do kind of like rudimentary assessment and referral of patients with oral health conditions. So the first is about doing risk assessment for dental disease. So for example, when you have someone that is a diabetic, a patient with diabetes, they are already at higher risk for oral health disease. So, you already know they're at high risk just by virtue of their medical condition. Being able to do an oral health evaluation, which is really just looking in the mouth and determining, kind of normal, abnormal, preventive interventions, and most of these are for children, like varnish placement, and being able to communicate and educate, again, informing your primary care patients with diabetes about the relationship between oral health and diabetes, so that they can, and helping them then to interprofessional collaborative practice really means to be able to to refer, to be able to identify dental care for your patients, in this case, your diabetic patients. Next slide. So in HRSA's latest, diabetes care initiative, you can see that in the middle column, one of the things in terms of optimizing provider and multidisciplinary teams is the ability for primary care providers to do, eye, foot, dental, and kidney screenings, just screenings, again, to be able to, normal, abnormal. Next slide. So in terms of just assessing, your patients with diabetes, again, just having that conversation, it's really like 3 questions. Are you having any problems with your teeth? Any pain, bleeding gums, problems eating? And when was the last dental examination? And who is your regular source of dental care if you have one? Next slide. So in terms of intraoral and being able to do the evaluation, you know, the signs of having gum disease, periodontal disease are classic inflammation signs. So bleeding, red, swollen gums, maybe pus exudate, you know, bad breath or bad taste in the mouth. Patients reporting that they feel their teeth maybe getting loose or separating, and that their bite is changing, or their dentures plates don't fit as well or don't fit the same. Next slide. So here you have some examples of what we call diabetic periodontitis, which again is a condition if a patient's usually out of control in their H1Cs and sugar levels. And this actually goes away, can go away and correct itself when they're back in control and we cleaned up the gums. But here you can see, for example, on the left, an example of like three things. One is that the teeth are starting to move. You know, they're starting to move because, again, there's been some bone loss. You can see the redness of the gums. And again, because these two individuals are probably out of control on their sugar levels at this time. And then you can see there's kind of this creamy exudate if you press on the gum that comes out. So again, they're having kind of like an acute episode of diabetic periodontitis. So if you see anything like these, any of these cardinal signs, you know, dental referral is indicated. And again, they're probably out of control. Next slide. So in terms of the referral, the interprofessional collaboration. So, you know, we're all working in health centers. So most of, you know, over 75% of health centers have at least one dental site. So, you know, you may be in a health center where if it's not your own site, you have another site where you can refer your patients with diabetes. And you can also get access to care for patients through contracting with, you know, other either nonprofit or private practice dentists. The challenges for patients with diabetes, and I'm sure you know them all, is, you know, Medicare doesn't cover dental benefits. So it would have to be if your state elects to cover adult dental benefits, which are optional. And even if they cover something, they may not cover periodontal treatment. You know, again, if you have undocumented or immigration challenged individuals, they're not going to qualify for Medicaid. So you have to, it's a question of what the priorities would be in your health center as far as accessing patients with diabetes for dental care. And always remembering that, again, if you look at HRSA's UDS numbers, the capacity of health center dental programs is about 26% of the primary care capacity. So not everyone in the health center can get into dental because, again, there's not parity in the capacity. Next slide. So some of the ways or strategies to access patients with diabetes in dental care, again, is to expand the access either through expanding health center dental programs or contracting with outside dental providers to see clients. As it relates to periodontal treatment, if you happen to have a health center that's near a dental hygiene program, you know, getting an academic partnership with that program so that students can rotate through your dental clinics, or, you know, even with portable equipment in your medical clinic, and do the cleanings, their periodontal treatment on diabetic patients. But really, if you want to prioritize on accessing patients with diabetes to dental care at your own health center, you're going to need that commitment by health center administration and the board to focus on certain priority populations. And you can certainly monitor and track that by having QA metrics, and we do have health centers that have these metrics every year of the percentage of patients with diabetes at the health center on the primary care side that also have a dental visit. Next slide. So these are some resources. The first one is a link that you can give to your patients with diabetes that talks about the relationships between oral health and diabetes, and the next two is actually one-page patient handouts that you can print out in English and Spanish that, again, you can give to your patients talking about diabetes and oral health. Next slide. And that's it. So feel free to contact me. There's my email. at NOAA if you have any more questions, either clinical questions or about how to access your patients with diabetes to dental care and integrating oral health into your primary care practices. So thank you.
Okay, all right. Thank you so much, Irene, for talking to us about the impact of oral health and diabetes. So we're going to move on to our final panelist. It's Tracy Tinker. So I'm going to just give me a moment to give Tracy keyboard and mouse control. So Tracy, you should have access to advance the slides. Okay.
Thank you. So today I'm going to review the rationale for adapting the ADA guidelines for a homeless population and talk about how the adapted guidelines can be used by clinicians in practice. And I'm really going to build a lot off of what Dr. Charrington was talking about with the ADA guidelines and also the social determinants of health and their impact as Dr. Leon was speaking. So the learning objectives for today are to understand the unique challenges that homelessness creates in successfully managing diabetes, and then specifically how we apply the adapted guidelines to improve treatment adherence and health outcomes. There is definitely a link between poor health and homelessness and poor health. So poor health is a major cause of homelessness, and then homelessness creates new health problems and can exacerbate existing ones. For homeless clients with diabetes, there may be no safe place for them to store their medications. Healthy meals can be hard to find, and harmful weather conditions in many parts of the country may exist. Frequently, there are behavioral health and substance use disorders contributing to both homelessness and poor health. These factors can lead to a higher risk of diabetic complications and make self-management of diabetes much more challenging. On the right here, you see the National Healthcare for the Homeless Council actually has the figure with the model on their website. And we've talked a little bit about the social determinants of health. So healthcare providers that are taking care of those who are homeless really need to recognize the need to adapt practices to the unique social determinants of health experienced by the clients. Clients who are homeless are much more likely to have an external locus of control. They feel like someone or something else is controlling their life. We hear this as sometimes statements like, I can't eat healthy because I need to get to soup kitchen or shelter and I don't have any control over to what I'm eating. Or, how can I take care of my diabetes when I don't even know where I'm going to sleep tonight? The adapted guidelines were developed to help the clinician address the unique challenges that a person with diabetes who's experiencing homelessness faces and partner with a client to create a client-centered diabetes care plan. These adapted guidelines are published on the National Healthcare for the Homeless Council website at www.nhchc.org. So the guidelines are also based on a harm reduction approach. So the harm reduction approach is commonly used in substance use treatment, and it's a client-centered, non-judgmental approach focused on reducing the negative consequences and risky behaviors to help clients affect positive changes in their lives. This approach can be used in diabetes management to help clients understand the consequences of unhealthy behaviors related to diabetes and then reduce the harms of those behaviors. Through this process, clients can understand how incremental changes in diet, exercise, and medication taking can improve diabetes self-care. Later on in the presentation, I'm going to share a case study that can show you how one client created simple goals and then identified barriers and strategies to achieve their goals. The adapted diabetes guidelines are broken out into diagnosis and evaluation, plan and management, management of associated problems and complications, and then there's actually a case study at the end. This really comes on this slide from the assessment part of the adapted diabetes guidelines. Importantly, to assess someone for their current symptoms, hypoglycemia and hyperglycemia, and any complications that are present. This can help determine what level of diabetes control is safe in a client. If the client is experiencing hypoglycemia and doesn't have access to healthy foods or access to foods to treat that hypoglycemia, you may not want to have the client have tight control because it might not be safe. I'm going to talk a little bit farther in on complications. I want to talk about medications and how clients can obtain their medications, their adherence to treatment, nutrition, where and how often are they able to access meals. On the left-hand side here, you see a picture. This actually is a picture of one of the dinners at our local food kitchen. We are a clinic that's located in the basement of the shelter, and the shelter also functions as a food pantry and a soup kitchen. So this is one of the meals for the soup kitchen. And many clients, as Dr. Charrington was talking about, may have comorbidities such as substance use or behavioral health. So we do use screening tools that are validated to screen for depression, substance use, and for diabetes distress. We have in-house behavioral health, so we have the ability to screen for depression versus diabetes distress, and then refer the patient to the appropriate person to be seen for that. Foot ulcers are very common in homeless patients with diabetes, so it's important to assess them for how much they're walking and what kind of footwear they're wearing, as well as do they have socks or clean socks to wear. And for social history, where are they living? How ready are they to change some of the behaviors that may not be as the healthy behaviors? And assess for literacy and health literacy. And just a quick comment on the health literacy and literacy is don't assume that a client who has very low literacy is not able to participate fully in their diabetes care. We have a client who is has a very low level of literacy, yet he has been able to do insulin adjustments every 3 days, increasing his insulin, and has moved his A1C from 9.8 down to 7.1. So just because someone has a low literacy doesn't necessarily translate into a low health literacy. And the opposite is true as well. Just because they have a high literacy doesn't always mean they have a high health literacy. One of the things that has been extremely helpful for helping with clients who are experiencing homelessness that have diabetes is the ability to do point of care testing in the clinic. This allows the clinician to make immediate dosing decisions and medication adjustments based on the A1C. In the past, if we had to have them go to the lab to have an A1C tested, they may not go, or they would go to the lab, would get the results, and it was very difficult to get the patient to come back to the clinic. So having point of care testing with a glucometer and A1C is extremely helpful because we can actually act on the information right away. Access to medications can be difficult. Medications are often lost or stolen, making adherence to a specific medication regimen difficult. In the next two slides, I want to discuss some challenges and some successes with non-insulin and with insulin therapy. For non-insulin therapy, all clients that are taking a sulfonylurea should be assessed for hypoglycemia. Clients who are homeless may be at higher risk for hypoglycemia due to the variability of their meal access and timing, and they may have limited access to a restroom during the day. So if they're taking metformin and they're experiencing GI side effects, that will need to be assessed. And then sometimes the longer acting formulations of the metformin might be a good choice for that patient. Also, liver function and alcohol use need to be assessed before starting and while taking metformin. Certainly, cost of medications and insurance formularies need to be considered. We have had some success with GLP receptor agonists, especially the weekly dosed GLP-1. So this can actually allow for the medication to be stored on site here in the clinic and administered weekly, so the client can come into the clinic and get their dose of their once a week GLP-1 receptor agonist. And we have had some success with a prior authorization process or ordering the medication through a medication assistance program through a manufacturer. We do have clients that are afraid to take their insulin because of a fear of hypoglycemia and not having access to foods to treat the hypoglycemia if it occurs. Therefore, as I said before, tight control might not be a realistic or a safe practice for patients who are currently homeless. Although mixed insulins might seem like a good choice due to the convenience of twice daily dosing, the need for a consistent schedule with consistent carbohydrates and consistent amount of activity is often unachievable for many of those clients. We have had clients that have difficulty with storing insulin because of a lack of refrigeration, or sometimes hot temperatures in the summer or very cold, freezing temperatures in the wintertime can certainly affect the stability of their insulin. If their client is using an insulin pen, they can be encouraged to speak with the pharmacy about dispensing just one pen at a time. And clients have told us that have a co-occurring substance use disorder who are in recovery that insulin syringes sometimes can be a trigger for them, making it difficult for them to remain in recovery if they need to use a vial and syringe to dose their insulin. They can also be targeted for theft of syringes if they're staying at a shelter, and especially where there could be a lack of resources for them to have a place to dispose of their syringes. All clients should be assessed for their tobacco use and their willingness at each visit to decrease or quit. It's important to educate clients on the link between smoking and complications from diabetes. We also assess blood pressure and adherence to their blood pressure medications at every visit. And they may have difficulty accessing foods that aren't high in sodium, and they may not have access to a bathroom during the day. So if they're taking a diuretic, that would be an important thing to assess whether they have access to a restroom during the day. And also checking liver function and assessing alcohol use for statin therapies, and access to specific renal diets for clients with nephropathy is often difficult because they're eating the foods at a soup kitchen or shelter, and they may not have much choice in what kind of diet they're eating. Access to eye exams are difficult, and our clinic has partnered with an ophthalmologist who comes to the clinic once a month and does eye exams for clients that don't have insurance. And the clinic purchases vouchers so that we can help clients obtain eyeglasses if they do need eyeglasses. I want to spend a little bit of time talking about foot care because that's a very important issue for many clients who are homeless. And the risk for ulcers and amputations are certainly increased, secondary to a higher prevalence of poor glycemic control, smoking and alcohol use, as well as the inability to offload weight. Here, our shelter is not open during the day, so although clients can sleep here at night, they do need to leave early in the morning, and they can't come back to the shelter until later in the evening. So many of them are walking long distances, carrying heavy bags most of the day. It's important to assess all clients for peripheral neuropathy and foot ulcer risk. Clients should be assessed at every visit, and they need to be taught how to check their feet. Make sure that they're actually taking their shoes off at least once a day and their socks to look at their feet. Many have neuropathy, and if they can't feel their feet, and they may have been given a pair of shoes from an agency or from the shelter that don't fit quite right, so they're certainly at higher risk of a foot ulcer. Also, as I just mentioned, offloading of weight, if they do have developed an ulcer, can be very difficult because they don't have a place to go during the day, so they're often walking long distances. It's important to encourage clients to ask their provider to check their feet at every visit. I actually remind them when they go into the provider room, as soon as they sit down, take your shoes and socks off so that they and the provider remember to check their feet at each visit. And do a lot of education for the client. When should they come in to see the provider? What should they notice when they do that foot check every day? What should they notice that's very concerning so they could get in and get their feet looked at? DKA can be of special concern. Recurrent DKA is much more common in people who are homeless, have a history of homelessness and incarceration, and are using drugs or alcohol. One of the things to assess clients for are, especially when you first meet them, is the number of times they have experienced DKA. And if you're finding that the patient with type 1 diabetes is experiencing recurrent DKA, it's often important to refer them to see the behavioral health team and conduct actually a diabetes distress evaluation to see if there is a specific area that you can educate them on, either as the diabetes educator or as the behavioral health team member. Also, for diabetic ketoacidosis or DKA, clients should be taught the signs and symptoms of DKA and when it's important for them to seek care immediately in the hospital. We use here for our patient education, we use the trans-theoretical stages of change model for goal setting. Pre-contemplation, the patient don't want to hear you talk about it. Contemplation is they're thinking about making a change in the next 6 months. Preparation in the next couple of weeks. Action, I'm doing it. Maintenance, I've done it, and now I'm still doing it. What's nice about our electronic medical record is we are able to partner with the client to set self-management goals and then identify barriers for them to meet the goal, motivation, and then put together an action plan. So you see in this slide, the action plan was to decrease from 2 sodas to 2 sodas weekly. What was happening is this client didn't have any access to any potable water that they could fill a water bottle. And in the convenience stores, the sodas were cheaper to buy than the waters were to buy. So what the client was going to do was only purchase 2 sodas a week instead of purchasing 2 daily. And he felt that he was in preparation stage for that goal, that he would be looking at it. He felt he could do it in the next couple of weeks. I'd like to finish with a case study. This is a 56-year-old male. He has a history of type 2 diabetes, peripheral neuropathy. He has some orthostatic hypotension, a substance use disorder, and schizophrenia. He was diagnosed with a Charcot foot and had a diabetic foot ulcer with osteomyelitis. He was released to the shelter from the local hospital with instructions for no weight bearing and had an appointment with wound care in 1 week. So you can see one of the issues here is he's going to the shelter. We don't have respite care in our area, so we know that to ask him to be no weight bearing was probably not going to work. He was advised to quit smoking, and he was given a prescription for nicotine patches, and he was given prescriptions for all of his medications. He has Medicare with support for paying the premiums and his copays, but at this point it was kind of towards the end of the month, and he actually didn't have enough of his Social Security money to pay for any kind of housing. So he ended up being readmitted multiple times. He spent 2 months receiving IV antibiotics. He was discharged and then readmitted the same day for bleeding after he walked on the wound to get wound supplies. He had multiple surgeries and they were amputating. He now has a below the knee amputation. He returned to the area, ran out of insulin and was re-hospitalized and then released to a rooming house. And the follow-up on this case study is he now has returned. I know it says here he hadn't returned. He has now returned to the clinic. He was able to see a behavioral health person to get reconnected for behavioral health. He is referred to the physical therapy for his wound and his prosthetic, and he is going to be coming in short term to come back to see the clinic. And I'll just finish with this quote, and I'll turn it back over to Tian. Thank you.
Oh, that's really wonderful. Thank you so much for sharing your experiences and how the adopted clinical guidelines. So now I'm going to stop showing our screen and look through the questions that have come in. So could, I think this question is for Dr. Charrington, and it's on the community health worker model and how, what kind of findings have you been seeing in terms of utilizing the community health worker model for diabetes management and prevention?
Yeah, okay, great. So to answer that question, I'll actually speak as myself and not as a representative of the ADA. So I have done research with the community health worker model for a number of years now, and we see a range of results when we use the that model for diabetes management as well as prevention. I can say that we see findings all the way from a reduction in the hemoglobin A1C on the order of, in the last study that we conducted recently here in Birmingham, it was a 0.6% reduction in A1C. We've also seen a reduction in diabetes-specific distress, which I think makes sense. If you think about diabetes distress being related to stress that comes along with managing a complex chronic illness, an intervention that provides direct emotional and sometimes tangible support goes a long way with reducing that kind of stress. And then just in terms of connecting people to local resources, I think that's one of the main benefits, in addition to the emotional support that community health workers can give. They just tend to know very well the assets that are within their own communities and can very often link people who may be disenfranchised from those resources. And that provides a real tangible benefit as well. So we started a nonprofit recently for community health worker services, and they provide all kinds of help to our patients, ranging from helping them figure out where to get their medicines to sometimes figuring out how to get a ride to the clinic, and a whole host of things in between.
Great, thank you. And then the other question that was also directed, I believe, at you was in your presentation, you mentioned some social determinants of health screening. Are you familiar with those screenings that are on the list?
Yeah, there is. I can't quote exactly the reference. I don't have it in front of me, but in chapter 1, there's a nice, very brief validated instrument that you can use for food insecurity. I think it's a 2-item screener that you can use for food insecurity. And I don't remember, I came on just a couple of minutes late, so Jose might have mentioned a screener around housing stability, so I would defer to him. The one that's listed in the Standards of Care in chapter 1 is actually came out of research done at the VA. So it's a VA, but it's generic, so it's not specific to the VA population. It's just that's where it was tested, and that's another validated instrument that could be used to screen for homelessness. I don't know, Jose, do you want to add to that?
Sure, thank you. The health centers that been working with, there is one in particular, La Maestra Community Health Center in San Diego. They have developed their own questionnaire to ask for social determinants of health, and they have included all the social determinants of health that I mentioned during my presentation. The other tool that I'm quite sure everybody participating in the webinar is the Prepare tool. That is a collaboration, and NAC is basically the entity that been putting together all these this particular tool.
Great, thank you. And OPTRO and Oregon Primary Care Association is also a partner in that Prepare work, so we can send that link towards to folks as well for the Prepare specific social determinants of health screening. But that is really all the time we have for today. I wanted to thank you, all of our panelists, for sharing their time and their expertise with us. Also, thank you for our participants coming on to the webinar today. We hope you found the information useful and relevant for your work. Here's the contact information for everyone that is on our call today, as well as links to our specific websites. There on our website, there's going to be a 4-part learning series for this whole webinar that's going to be housed in one place. So you'll find the link to that in the email after the webinar. And then I just want to plug too, the Social Determinants of Health Academy. Next session is on March 8th about pathways to cross-sectoral partnerships to address SDOH. And with that, we're going to end the webinar, and please don't forget to complete the post-webinar eval survey so that you can receive your appropriate credits for today. Okay. All right. Well, thank you, everyone, and have a wonderful day.
Great. Thank you.
Thank you.
Bye.